Welcome to the Ortho Joe Show, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. In our world, orthopedic research is king, and current topics from our respective publications are analyzed weekly. Here is Mohit Bhandari from Ortho Evidence and Mark Swinkowski from the Journal of Bone and Joint Surgery.
Well, welcome, everyone. Welcome, Mark, and welcome, Mike McKee. I'm going to give you a proper introduction. But first, we have to, merch this out. We have a cup here, Mike, that you will see is going to change your life.
Exactly.
It provides all kinds of great fluids, and I'll trust you put whatever fluid of choice you have, but for us, it's coffee this afternoon. Let me just take a moment also just to...
Let me just say though, Mike, it does hold Molson's.
Okay, good. Then we're good to
go. Doesn't need an introduction, but I will give one to Professor and Chairman of Orthopaedic Surgery at the University of Arizona College of Medicine in Phoenix, and immediate past president of the Orthopedic Trauma Association. For many of us, he has mentored us in so many ways. And I think tonight and this evening, this is an evening edition of our Ortho Joe session. We're going to really dive deep into, I think some of the things that have been real impacts in his career, and probably get some takes on some of the challenges with some of the research he's done and some of the impacts he's had. Mark, from your perspective, when you think, and I'm going to ask you to start first, and the reason is I want to get your take on this. When you think about Dr. McKee's impact in orthopedics, what's the first thing that for you comes to mind?
Well, I think Mike's been one of the real leaders in establishing the multi-center trials in fracture topics, and a real leader in the main topic we want to talk about tonight, clavicle fracture. I can't think of a bigger change in the way we've managed patients in my career anyway. And Mike is responsible in large part for that change, but a real leader in establishing the framework to do multi-center trials, first in Canada and then adding worldwide trials as well. So he's a real leader, pretty decent hockey player as well. But he has too little faith in the Maple Leafs these days, I think. So particularly after last year, but we don't want to talk hockey because we're way off topic here.
Sounds good.
Okay, so I don't know, Mark, if you want to lead off with. Usually it's a publication, but I'm happy to also. I've got lots of questions for Dr. McKee.
Well, if you don't mind, so the key paper was 2007, if memory serves, and it was the Canadian Orthopedic Trauma Group. On the randomized trial of conservative care or non-surgical care versus surgical care, and it was a real game changer. And then I think McKee and McKee, there were two McKees on the follow-up meta-analysis that came out in 2012 that pooled data from 6 studies, which further enhanced the major findings, being that the functional outcomes were better with internal fixation. And that symptomatic malunion and non-union were a real worry for those treated non-surgically. And I think these two papers are the major ones, but of course there have been many trials that have sort of backed up those seminal findings. But what I would say is that it's pretty clear to me that the inclusion criteria for both the COTS trial as well as subsequent trials were significant displacement. And what I've seen just in my part of the world is that the indication has drifted towards the fracture of the clavicle as the indication without displacement. And Mike, I don't know if you see that in Phoenix these days or you were seeing it in Toronto, but there seems to be a lot of drift in the indications. And what are your current thoughts now?
Well, I agree. When you look back at that study that we did, it was for a very specific set of fractures in a very specific population. And, the impetus for that study was that we were seeing so many patients who were coming to us with non-union and symptomatic malunion after fractures that we thought maybe there's a better way to do this than to leave them all alone, which was traditional teaching. And like you, I don't think I ever fixed the clavicle fractures as a resident, whereas now it's one of the more routine things we do. We decided to pick a healthy population, so age 16 to 60, with a completely displaced fracture. We talked about trying to measure displacement. It was actually quite difficult to do, and there's a variety of different ways to do it. So we just said there had to be complete displacement. And in that study, that worked out to fractures that were on average about 1.5 centimeters or almost 2 centimeters short and 1.5 centimeters depressed. So significant displacement on average. And we found that for those healthy, active patients, they did pretty well when it was fixed surgically. It was a technically highly successful surgery. It's within the grasp of the average orthopedic fracture surgeon. And there's some significant benefits to it, including a much more rapid return to function if you look specifically in your outcome criteria for that specific outcome. It's hard to pick up more rapid return to function unless you do some examinations early on in the process of the post-op period. And that was replicated by more than a dozen randomized trials now, have really shown more of the same thing. It's interesting that some of the conclusions from those studies are different from our conclusion, but the actual raw data in almost all the clinical trials done is very, very similar to what that original study showed. And if I could just give a shout out for our research team at the time, there was another similar study done that was never published because so many patients were lost to follow-up. And our research team was so good at getting patients back and so dedicated. Lynn Vicente and Lisa Wild, they got all those patients back, and that made a huge difference for our study, as well as the other research coordinators around the country. I have seen some indication creep, shall we say, both in terms of the patient's profile and also the degree of displacement. And it is a bit concerning. Most clavicle fractures that are minimally displaced or moderately displaced will heal well and fairly promptly in most patients. The surgical risk goes way up in diabetics, substance abusers, non-compliant patients, et cetera. So personally, I'm very, very selective as to who I fix in those settings. But we need to be careful that indication creep doesn't continue, because it's not a good thing in general.
Along the same lines, Mike, like I went back and I looked at 7 years ago, there was an Ortho Buzz. Ortho Buzz is, in this particular case, Ortho Buzz is sort of the editor's choice. And Marc, I believe it was your very first Ortho Buzz on your editor's choice, in which you actually had named this trial as being the seminal trial. And you had put out a couple of statements. And along the same lines, Mike, after that study, there was an explosion of ORIF for clavicle fracture of the midshaft. But Marc had written at that point, we should not misinterpret the COT study findings. When you look back at all the different interpretations people have talked about, is it really just about the displaced, undisplaced issue? Or what are some of the other common ways in which that study you think may have been weaponized in a way that wasn't necessarily your intention and in your guidance in that paper?
So that's an excellent point. And if you think back to that period of time, really no one fixed clavicle fractures. And we came out and said that there are some specific advantages of fixing them, and we're quite emphatic about it, because we had to say something that was people would notice, if you know what I mean. The pendulum had been so far swung to one side for so long, we had to do something to kind of tease it back towards the middle. So we're quite specific about it. The paper never said you have to fix every clavicle fracture you see. In fact, the paper never said you had to fix clavicle fractures in a specific group that we studied. What it did say was that here are the numbers. This is information that's good. You can use it with your patient to decide on a course of action. And if you want to tell your patient your fractures is 70% chance of healing, given enough time, if you leave it alone and you'll probably be okay, that's perfectly acceptable to us. And that's the truth. If you're unhappy with 30% failure rate, either non-union or symptomatic malunion, and you have a reason to get back to doing things a bit more quickly, then surgery has some definite advantages for you and the risk is low. And that's all we ever said. We didn't want it to become absolute standard of care or standard practice guideline. It's information that is accurate, and we did not have information that was accurate before this study, in my opinion. It was information that was accurate about the benefits of fixation that you can use in a discussion with your patient to come to a mutual decision about what to do. And I think that I've heard people say, oh, you've got to fix these, you've got to fix these. That's not the case. You've got to have a good discussion with your patient about the advantages of it, and then you can go from there. And the disadvantages. Now, that study didn't really show it, but since then we've shown that plate removal is a major issue in some people, especially if they're thin or short, et cetera. So there are other issues there that have subsequently developed from that.
Yeah, I think what the situation has evolved now is that patients come expecting that you're going to tell them they need surgery, because most patients, particularly in the athletic population, they know somebody that's had their clavicle fixed, and it takes twice as long or 3 times as long to talk them out of surgery as it does to sign them up and do the procedure.
That's exactly right. So, I mean, I've had interesting cases where, a medical student would see a patient in the ER and say, "Oh my gosh, that should be fixed." And when they come to my clinic, I'm standing there as the professor trying to convince them they don't need surgery. And they're like, "Wait a second, I heard it should be fixed, doctor." It's like, it takes much longer to convince them that you don't need to have this done. And that may not be accurate information. But you talk about sports groups. So early on, a number of the bicycling groups, bicycling is a very common mechanism for this. They were on their website saying, "Hey, if you get this fracture, here's a list of doctors who will fix it because it needs to be fixed." It was tremendous push from those groups to get the fractures fixed. And it has become the standard of care in the NHL and the NFL now. If you have a displaced clavicle fracture, it gets fixed surgically. There's some anecdotal evidence to support that. You get back to playing quicker, and what typically is a short career, and your chance of re-injury is less. But the sports groups definitely did promote this to a large extent.
Mike, you've thought a lot about how to fix these. What's your current thinking about? Will there ever be an intermediary implant that will be useful and really move plating out of the way?
Yeah. So by way of disclosure, I should disclose I'm a designer of clavicle plates, and so obviously that's a potential bias on my part. I have used IM devices for the clavicle. The one I was most interested in was a flexible. Was a nail that contoured the shape of clavicle, and you could lock at both ends. I don't think that's actually in production anymore, unfortunately. I do think that if you can design an IM system that you can do a fracture of this nature percutaneously and give it some kind of length control and rotational control, that would be an ideal solution. Would help minimize plate removal rates. And plate removal is, remains the most common operation that's subsequent to having it fixed, is having to have the plate taken out. And you could argue about what the rate of that is. The IM devices in Europe, the smooth elastic nails, they seem to do fairly well in perhaps a physically smaller and more compliant population, but there's a high rate of removal in those as well. The more complex the fracture pattern, there's evidence that, the unlocked IM devices probably don't do quite as well as the plates. So I definitely think there's a role for IM devices. I was disappointed that the one I had used for a while seems to have been withdrawn from the market. But at some point, I think that it's going to be possible. I think the ideal patient for an IM device is someone who has a canal big enough to accommodate it. And definitely we see clavicles with a 1 or 2 millimeter canal very tight, especially in smaller young people where it's just not feasible to put one of these devices down, or a simple fracture pattern. So when I did use them, it was simple fracture patterns, big IM canal. That was actually a very successful device for me. But as I say, I don't think the perfect device has been designed yet.
Mike, can I ask just a broader question, maybe a bit more philosophical on this topic? When you, in 2007, saw or probably even prior to 2007, completed the trial, you saw the results. Did you have any idea what this study was going to do? Like, did you have a sense that this is going to be one of your probably most cited papers in your resume? You've got lots of cited papers, but this was going to be the study, and that looking back, you would almost become synonymous with, this particular bone and this particular treatment. And it's almost like, it becomes so overwhelming a brand associated with the work you've done. Did you think it was going to get that big at that time?
Well, you're right. The study was published in 2007, but I had the results long before that, because the editorial process at the JBJS was so long and painful. It just took forever to get it out. Oh, sorry, Mark. You digress.
Well, mind you, I took over in 2014, so no offense.
So it's not your fault. Okay. I thought that it had the potential to change practice. Yeah. So I've done a few studies in my career where I thought we had the potential to change practice on a limited basis. Did I think it would take off the way it did? Frankly, no. I thought that, we would see maybe some people changing. We know that at times it can be very difficult to change orthopedic practice and change mentality of people. But I was very surprised to see how it took off. And I think one of the reasons it took off is that the data was good. The data was reproduced in a number of other studies. I would have people say, oh, we're thinking of doing that study, and then we saw yours, so we stopped. And I said, no, we want you to do studies in Britain and Holland and the States and see if the same results occur. We need that to know whether this is something that translates to all different populations, or whether it's reproducible or not. So I think that the data was solid. It was reproduced a number of times. This is an operation that's within the technical grasp of most orthopedic surgeons. And as opposed to a periosteal osteotomy, which is a great operation, but let's face it, there should be 2 or 3 people in each major center, each major city doing that operation. Everyone doesn't do that operation. And so it was, and then when you have a patient, so you fix a displaced painful clavicle, they're probably the happiest patients in your clinic. Like, it's instant gratification how much better they feel. And it's logical that it would be that way, how much more quickly to get back. And that's why I think it became so popular, because it's true, and those patients do very well initially.
Yeah, thanks.
Yeah, so Mike, you've stated a couple times in this interview that it's within the grasp of the average orthopedic surgeon. So I have walked into the operating theater when watching a colleague from a different subspecialty other than orthopedic trauma, and look at what they're doing, and the clavicle is stripped 360 degrees with clamps circumferentially. I wonder if you could say a few words about the surgical approach and what's the way this should be done.
So I'll talk about plating, for example. I tend to be a superior plater. There may be a role for anterior plating, and I think there's some evidence that that's the case. Maybe the plate removal rate's a bit less. Some people now use mini fragment plates, 2 plates, that kind of thing. But in general, what I try and do is, and we try and emphasize this in the technique papers that we publish, is if there are pieces, if there's comminution, if there's no comminution, it's pretty straightforward, and you don't need to strip circumferentially, just where you're going to put your plate, clean up the fracture site. There's comminution, it's big enough to fix. I try and K-wire or lag that piece or fragment to either the proximal or distal fragment, and make it more of a simple fracture pattern, and then reduce that. If the cost of replacing that piece back where it belongs means completely stripping it of soft tissue, then that's not worth doing. You want to try and bridge that fracture with length and rotation correct, and then go from there. Most pre-contour plates will very much help you do that. So if you have to completely strip a fragment to get it back where it belongs, then that's not a win for that particular fracture. And I've seen, I have referred similar cases to me where it's obvious that was what was done, and that's not a win. And despite that, most of the time, even when that's done, those fractures tend to unite, surprisingly enough. So
right, I too am a superior plater because the pec origin is on the anterior surface of the bone, and you take it off to get a longer screw. It makes mechanical sense. It doesn't make biologic sense. So
I've seen enough, and this is not to make this anecdotal medicine, but I've seen a number of patients who have had an anterior plate, and the pec hasn't healed back up where it was supposed to, so it kind of sags down. And those tend to be particularly unhappy patients because they have no benefit and a bad outcome from having that approach done. I think if you are going to do it, you want to make sure you get that pec back up where it belongs and secure it there. And that's important no matter how you plate it. I like to have 2 layers of soft tissue, a layer of fascia and muscle, and 1 layer with some absorbable suture, and then a separate skin layer on top of that. So you have 2 layers between you and any potential infecting organism.
Mo, I'm going to let you get the last question in.
Yeah, having thought about this problem for, well over a decade, if not probably approaching 2 by now, Mike, what's left? Or where do you think future research in the area of clavicle fractures is going to be taken?
So I'll say right now, the adolescent clavicle fracture. So that's a huge area of controversy right now. And for the patient, sort of 14, 15 to let's say 19 with a displaced fracture, we really don't know what to do. It's clear the non-union rate is lower in that group, but it's not 0. And even when it heals, there are some patients who are significantly symptomatic. So those of us who do referral work routinely see adolescents with displaced fractures who have it treated non-operatively and who come to see in the clinic and are very unhappy with their results, okay? I know that there's a number of papers out recently that say that most of these can be treated non-operatively. That's probably true. I think it is true. But it's not clear from those papers who should be fixed. And I'm convinced that some of them should be fixed. And we don't know in the adolescent who that is and who that isn't. I've seen patients, 15-year-olds with 3 or 4 centimeters literally of displacement. Their shoulder is completely asymmetric. To go and see a pediatric orthopedic surgeon, and then they get told, oh, this will all be fine, just leave it alone. The parents come to me for a second opinion saying, we want this fracture fixed. And it's the exact same scenario I used to see in adult fractures in the day. And they say the same things about the surgeon. No, we told him our son wasn't happy. He didn't listen to us. This isn't right. It's not good. Same thing I see from adults. And so I think most of them can and should be treated non-operatively, no question about it. But there's some that should be fixed. And we don't have the study that shows that right now. And we need that from our pediatric colleagues. We need some kind of prospective randomized thing with the worst fractures in certain age groups to see what should be done and what shouldn't be done in that age group. And secondly, I say trying to find a way to minimize hardware removal would be a good thing, practically speaking, going forward. That's still a common second operation after you have your clavicle fracture fixed. And we can find a way to decrease that. I think that'd be very beneficial. So those 2 things, I think, would be something I would focus on.
Great, wonderful, thank you.
Some additional things to work on, but Mike, congratulations on really changing the practice for the care of this fracture and all of the work of you and your colleagues. I think it's totally right to give kudos to the research coordinators, which really enable all these studies to function and come to fruition. But you've made a major contribution in this area and others, and we thank you for visiting with us on Ortho Joe, and I hope that you don't have too many more patients to see or meetings to go to, and you can go have a brew. And the last thing I'll say with great confidence is go Leafs.
Go Leafs, go. Thanks very
awesome.
much, Mark.
Thanks, Mike.
This could be the year.
I hope so.